Sure. Okay, so I'm Dennis Porto. I am a physician. I'm a practicing dermatologist. I first got interested in blockchain and Bitcoin back in 2013 when I think just read like a random news article about it, and it was like it was contagious. As soon as I had first read about it, I was kind of off to the races. I was thinking about it every day. I ended up sending. I was telling Professor Cohen. I ended up sending loose yen in the mail to Mt. Gox at the time to buy my first Bitcoin back in 2013. And so these evolved kind of as parallel interests, both kind of healthcare and medicine, for a few years. And then just recently I completed a master's program at Harvard and was really encouraged to merge these interests. And I kind of made it into more of a niche now. And oh, thank you so much. And so I do some speaking about blockchain, and I've used that initial investment in Bitcoin to start making some angel investments, and I've formed an angel syndicate with some of my classmates at Harvard. So, I'm also, I should say, writing some Harvard Business School cases, which is kind of the curriculum for Harvard business students. I'm writing some about blockchain as well. So, so I try to do both medicine and blockchain. So I'm going to be talking very briefly. We only have, I think, 5 minutes for these talks. I'm going to talk about a framework for how I use to evaluate projects in healthcare and blockchain, and then I'll apply that framework to a number of specific opportunities, show how the framework works, and if we have time, I'll just mention some brief pitfalls for blockchain as well. So a question that people often have is, when people first hear about blockchain, they often want to apply it to literally everything. They think it's like the internet, internet everything, blockchain everything, etc. And that's really not a good approach. And instead, I worked with Deloitte a little bit when I was a master's student, and they came up with these basically 4 checkboxes or 4 criteria for whether a project is a good fit for blockchain. And these basically capture the value proposition of blockchain. So when you have multiple parties that all want to interact with the shared ledger, and the parties may or may not trust each other, or if the intermediaries that in the past, the traditional intermediaries are inefficient, and there's a need for enhanced security, then if you can check at least maybe 3 or 4 of these boxes, then blockchain could be a good fit for you, because that's really what blockchain offers. So if you think about medical records, for example, it really does a good job at checking all 4 of these boxes. So with any medical record, you have physicians who want to access it, and more patients are accessing the medical records, and dietitians, and pharmacists, and nurses, and payers like the government or private or insurance companies. And so all of these disparate individuals, some of them with competing interests, some of whom may or may not trust each other, they all want to be able to interact with this shared database in a trustless, transparent, fair way. And so that's something that blockchain can offer, and that's why there's some exciting startups in this space. Furthermore, the traditional intermediaries of patient health data are really, there's lots of problems with it. They're very inefficient. So right now, patient data by and large is owned by hospital systems or provider groups. And that's a big problem, for example, if you're a patient at one hospital that's transferred to another hospital, a lot of important health information can be lost, and then that can result in patient morbidity and mortality. And so this is a big problem, especially in the United States, where health records are almost like proprietary information that not everyone has access to. I know as a physician training, I oftentimes, as a resident on the front lines, I would receive a patient from another hospital, and I would have to kind of scramble to find the records, and it would take hours, and I oftentimes not ever find what I'm looking for, and it's a problem that blockchain can help break down these silos. And then finally, especially in the United States, HIPAA privacy laws are very important, and there's different cryptographic techniques and the way that the blockchain is structured that can afford enhanced security as well. So outside of medical records, there's a number of other opportunities that I think are valuable. The first is if we are able to, let's say, onboard an entire nation's populace onto a shared and standardized medical record, that would then enable population researchers to have this access to this huge amount of standardized data where they can find little nuances, maybe different medications or different associations between medications and illnesses that a patient might have, and they can make clinical discoveries based on those little nuances that they see. And this would be something that's not possible if they had fewer patients in this database. And so there's definitely population research opportunities by using a health record that's based on blockchain. Also, so supply chain is one of the best use cases, one that's actually being used today in blockchain. And there's, for example, a Harvard Business School case on MERS, which is using blockchain that was developed at IBM to help track the shipping supply lines. MERS was a big international shipper, and there's all these different stakeholders from the the manufacturer of a certain good to the shipper themselves to the truck that the supply goes on to, all the way to the end user. And so in each of those handoffs, there's a risk of the goods being tampered with or being mishandled. If you think, for example, in terms of pharmaceuticals, if you think of like a vaccine, for example, there's a vaccine manufacturer, and then it has to be given to a distributor, and then to the pharmacist, and then eventually to the patient who receives the vaccine. In each of those little handoffs, there's a chance that the medicine could be diverted or counterfeited. We think that these things don't happen, but they really do, and they happen a lot more than we think, especially when we're dealing with an international supply chain. And so whenever there is a risk of diversion, for example, with narcotics, you can really, there's a good chance that blockchain could help in preventing diversion and making sure that the supply chain is intact. And I included needles here because needle exchanges are another use case, or even cannabis dispensaries, to really make sure that you're rock solid about the supply chain, you're not losing things to diversion or corruption, etc. And provider credentialing is another important topic. I don't want to steal Dr. Houston's thunder, so I'll let her talk more about that, but I think that it's okay. Well, I'll leave it at this, that for example, right now I'm applying to practice medicine in the state of California, and it takes me 6 months to make that happen, and I have to coordinate all across the country with different testing agencies, proving that I passed my boards, and my medical school, proving that and then also I have to do fingerprints, proving I'm not a criminal, and all these other things, and it's unfortunately a very costly, time-consuming ordeal where I could be seeing patients and helping people, which is what I'm supposed to do as a physician, not kind of filling out these paperwork and things like that. So provider credentialing, by kind of having a universal database that's trusted or trustless, as we say in blockchain, that would be very valuable. And then very briefly, I'll just mention some pitfalls that many of us I'm sure are aware of with blockchain. So right now, a lot of the blockchains, especially the most established ones like Bitcoin, are based on proof of work, which is very energy intensive, and lots of the blockchains, even the ones that aren't based on proof of work, can have some scalability challenges because you have to, the way that blockchain works is all the data is redundantly held between many computers, so it's not really the most efficient use of data handling if you don't need it. So that's, again, why you want to make sure you check all those boxes and are only kind of using blockchain where it's absolutely needed. And then finally, there's a lot of regulations, especially in healthcare and HIPAA privacy laws, and how blockchain will fit into this remains to be seen. And it's going to take some talking with regulators and thought leaders and patient advocacy groups and privacy groups. That's it. So blockchain, I think, has enormous potential. It's not a solution to every problem. I'm excited for our panel, and you can email me too if you want to talk more. Thanks.
Oh, there we go. I'll try not to bore you guys. So I'm Dr. Leah Houston. I'm a board-certified emergency physician. And full disclosure, I also am the founder of a new startup that's going to use blockchain to credential physicians on a distributed ledger. So I'm going to talk about barriers, but I don't like the term barriers really. I like the term hurdle because a barrier seems permanent, and a hurdle is something that you can go over. So opportunities. In order to understand barriers, we need to understand the opportunities first. So we've spoken a lot about medical records, research and development, supply chain. We mentioned provider data and credentialing, as well as payment is also another use case. And the pain points in healthcare really are around security and interoperability. Healthcare systems are really bad at this. They have lots of data breaches. They don't talk to each other. There's siloed systems all around. So I'm going to talk about history very briefly. I'm going to talk about the World Wide Web and the Internet. 1991, is when the World Wide Web was started. And that was about 27 years ago. It took about 10 years for it to be fully adopted. And about 5 years from then, people started talking about it in Silicon Valley. So think about like the dial-up America Online moments. That's about where we are right now with blockchain. There's some use cases, they're slow, they're inefficient, but in about 5 years, I think we're going to have mass adoption. And 15 years from now, it's going to be part of our daily fabric. So this is the Satoshi white paper. I didn't mean for this to go so slow. So, but basically, he had this Genesis block on this date, and that was about 7 years ago, as I said. So where we're at now. Some more history. The first regulation was in finance. The second one was in healthcare. So this is a diagram of our healthcare system. It was put out after the ACA. So it's very, very simple. Just take a look. And if you notice, the Secretary of Health and Human Services is at the center. And where's the patient? Can anybody find him? I think he's actually behind this podium down there. Okay? And the doctors are also all the way in front over there. But so this is the healthcare system that they designed for us. But this is the system that I hope that we have in the future when we start implementing blockchain, where the patient is at the center and all the other systems are working for the patient. And I actually think that a lot of these systems will kind of fall away because they won't be needed because they're trusted third parties that we won't need any longer. So barriers to adopting any technology in healthcare, we have regulations, security, interoperability, scalability, and culture. And you think about the three players that basically are going to create barriers. The people that are going to adopt it, enterprise, and government. And when we look at this slide, we want to think about those opportunities that I talked about, how they're interacting with these different intermediaries. So this is government. So we have CMS, Food and Drug Administration, DEA. So CMS, they're the ones that govern how we deal with medical records and how we deal with payment when it comes to government-funded insurance. As far as the supply chain, that would be the FDA that regulates that somewhat. And then we have the HIPAA and the HITECH Act, and that's also, they have implications for EHR. And when you look down at the bottom, the FSMB, that's the Federal State Medical Licensing Board. They're the ones that regulate provider and physician data. And what else? Oh, the National Institute of Health. They're the ones that would regulate the research and development portion. So those are the 5 opportunities that I talked about. The ONC actually is took a step ahead. In 2016, they asked for white papers in the healthcare space. So that was really interesting to read those. So here's enterprise and all the players in enterprise. So again, we're thinking about 5 opportunities. So medical records, we see Cerner, Epic, T-System, Meditech. Those are some of the few. And they really control how medical records are governed. They're not communicating. They're in siloed systems. There's no interoperability. They're extremely clunky, and doctors don't like using them. As far as research and development, we think about the pharmaceutical industry, Novartis, Purdue, Merck. These are just some of them. And they also don't need to share data. They don't want to get rid of any of their intellectual property. You know, there is a possibility for them to have closed blockchains that they put their own data on so that they can do their own research and development in-house. But it would be really nice if they had a tokenized incentive to share amongst each other or something like that. But will they adopt that? Who knows? And as far as the supply chain, some of you might or might not know GPOs and PBMs. They're pharmacy benefit managers, and they basically control the supply chain of drugs. So we hear a lot about drug shortages, and we wonder why do we have shortages of things like normal saline, epinephrine, life-saving medicines? They're not that expensive to make, but they are expensive to get into the system to get through the supply chain because these entities have basically protection by the government under safe harbor law to accept kickbacks in order to get these things into the supply chain. So they're going to be a huge barrier to entry. They don't want to have any price transparency. They don't want people knowing their backdoor deals. So that's another barrier. And then, of course, with payment, we have the insurance models. We call them BUCA, Blue Cross Blue Shield, United Healthcare, Aetna, and Cigna. And there's a lot more, but those are the big ones. And, you know, as you mentioned, the number one barrier to adoption is going to be the people. There we go. And the people are the ones that are causing security breaches. They're the ones that are opening up these emails, that are downloading ransomware to the hospital healthcare system, software, and things like that. So people need to be educated, they need to be aware, but we also need to create good front-facing applications so that people want to adopt. We need to allow this type of technology to improve the doctor-patient relationship rather than disrupt it, which currently technology only disrupts the doctor-patient relationship in healthcare. So that's the end, or maybe the beginning.
I don't have slides, but just briefly talk about it. Hey guys, I'm hot. I will make it a very short. So I think Leah and Dennis already talked a lot about the barriers and opportunities in blockchain. Oh, first, like personal introduction. So I work for Google. I started like working and studying Bitcoin since 2013. Actually, took a course in Stanford following biology, CTO of Coinbase right now. Ever since I started studying the blockchain technology and engineering, also doing a lot of token investing. So right now I'm working at Google. I'm mostly doing the blockchain engineering. So I can briefly talk about what Google is doing publicly. So we have a DeepMind division in UK. So we actually have a healthcare division also inside DeepMind. So we actually started a pilot project with UK government. So we put all the, we actually build an integration protocol based on some kind of, a Merkle tree, the data structure underlying the blockchain. So we build a system actually making sure all the UK citizens' healthcare data is, the usage of the data is monitored. So no matter who, when, and where, how much data is used, the actual log trail is actually logged onto the decentralized distributed ledger. That's basically what I'm working on in Google. So as per the opportunities and obstacles of early adoption of blockchain in healthcare system, actually I'd like to add 2 more points. So actually, there are 2 points Dennis and Leah have mentioned. So one is the privacy. So blockchain, with zero knowledge proof, the technology underlying the cryptography, supposed to be users are able to control their own data. So and to use those data, they don't necessarily reveal the data itself. So in that situation, it's actually empowering the use case of population healthcare data. So basically, it's kind of anonymous of like a data format dedicated to some kind of a specific demography. So you can do a lot of AI machine learning stuff and analytics around that. In the meanwhile, there's the immutability part, which is actually I mentioned what I was working on. The blockchain as an immutable ledger, it make sure the data integrity and authenticity of the usage of the data itself. Like you basically can build a log, like the auditable log itself. So that's basically me, and we can jump to the discussion. Thank you.
All right, so now we'll have our panel discussion. So I'm thinking back, so one of the last big digital changes in healthcare was the electronic health record, and when it first became available, I remember I said, oh, this is great. I remember when I was an intern, I'd go down to the medical records department, I'd have a complicated patient, get 5-volume paper chart, and I'd spend hours going through it to find that one piece of clinical data that I needed to take care of that patient. And I said, well, wouldn't it be great if this was all digitized and I could search it and so forth. And obviously the electronic health record has been great for Cerner and for Epic. And as somebody mentioned, I think you mentioned earlier, that PARK has spent $1.7 billion buying an Epic system. And it works, I think it works really well for them because they can really make the billing of the insurance companies really effective and bill for every possible thing that they can. But when I go talk to my friends who are still in clinical practice, I say, how's clinical practice these days? They say, terrible. And I ask why. It's those damn electronic health records. I spend a good fraction of my day being a data entry clerk, so a hospital can bill effectively for the patients, and I see fewer patients now. I can't spend as much time with the patients. So I think this was like a totally unanticipated, it's not what I anticipated, I don't think physicians anticipated. So one of the questions I have is, how do we prevent these unanticipated consequences, and how can we test these systems? There's a difference between something being a success for a business and getting it adopted, and another thing is being good for the patient. And I think we need to build in testing regimes to show that we actually have improved patient healthcare outcomes. So why don't I leave it at that and look forward to having a comment on that.
Sure. So I can start. So I try to avoid making kind of broad, sweeping statements, but I'm going to make one now anyway, and that is, by and large, physicians do not like electronic medical records. And I'm saying that as someone like a millennial who was brought up always on the phone and always on the computer, and I'm very digital savvy, but like Professor Cohen says, it slows us down. So it's that being said, there are some benefits of electronic medical records from a provider's perspective. I can check on lab results at home. I don't have to go into the clinic or into the hospital to kind of follow up on things. I can do it at my leisure, which also helps the patients, which is the most important thing. But we're missing so much of the upside and the promise of electronic health records. And I think the key is that we don't have that interoperability that we were promised with health records. And that's something that blockchain can help. They can help break down these data silos, which are so much of the promise and so much of what's missing in today's digital health landscape.
Yeah, so from my side, so I think there are two approaches to this problem. One is, I think blockchain technology itself, you can say, you can create a blockchain from a very bottom to top approach. But however, to building a healthcare system is mostly a top-down approach. So like when actually it really needs a government push into the digital healthcare system. If you look at the Estonia government, they have 95% of healthcare data is in digital format, 99% of prescription data in digital format. But let's look at the United States, look at China, that's not the case. You still have a lot of paper version. However, there is the other side, bottom-up approach, which we can use a blockchain to do that, which is blockchain. In essence, it has a built-in incentive system. So if you allow a digital healthcare marketplace to build up upon the blockchain, it's possible like you make users themselves like opt in to such kind of digital system. Like they will ask doctors, hey, I want to monetize my data, so you need to put my data into a digital format.
Yeah, I totally agree. If government were to step in and make things interoperable and make them easy to use, then it would make everybody's life easier, patients and physicians that care for them. I don't necessarily agree that it needs to be a top-down approach, though. I think bottoms-up would be fine. And full disclosure, this is part of what I'm trying to work on. allowing physicians to design these types of systems that they're the ones that they're using every day. Physicians were the ones who trained how to take care of people. They are the ones that actually talk to their patients, so they understand what patients want and what patients need. And so, first of all, I appreciate that physicians are being included in this conversation, because I think a lot of the mistakes that have been made in the past, it's because they haven't been. And we have a lot of administrators and bureaucratic entities creating all these rules and regulations that now we have to deal with that aren't helping us. So, yeah, I think that including physicians and patients, the ones who actually matter in the conversation, would be very helpful.
Great. Well, let me just go on a little bit more in terms of the electronic health record. So, one of the speakers this morning said blockchain is slow. So, slow EHR is a definite non-starter. I mean, when people are spending too much time, physicians are spending too much time as it is, and any system that comes up is going to have to be very quick. It takes an extra minute per patient. Physicians are going to be very unhappy. And then there's another issue, and I wonder if you've thought about this, is that everybody assumes that getting more data to the physician is great, but the truth is physicians are overwhelmed with data. And I see lots of little companies that that I talk to, and they say, "Oh, I've got this great patient monitor, and we can measure the blood glucose continuously, and the heart rate, and the blood pressure, and all sorts of other physiologic measures." And I said, "Well, what are you going to do with that data?" They said, "Oh, we're going to stream it to the physician's office." I said, "The physician's office does not want to see that. They have no time to deal with it. Who's going to pay for them looking at that?" So it's not only a question of getting data to the provider, but it's trying to figure out how the provider can use that information. And once again, the time pressure is essential. Providers have no time, and they're very, very pressed. And so, unless technology makes their jobs easier, there's going to be resistance to adoption. So I wonder if any of you have thought about that issue of data overload.
Yeah, so I will comment first. So I definitely agree 100% that physicians don't want more data. And that's not the kind of goal of interoperability or blockchain in my perspective in some of the projects I've worked on. I think that instead physicians, for example, when a patient is transferred between hospitals, they're going to want that data from the outside hospital no matter what. Not because they want more data, but they want that specific data. And so that's what blockchain enables, is to honestly cut down the time that the physician would have spent trying to track down outside paperwork. So it's more of a time-saving thing rather than a burden on the physician. Another point, as far as you mentioned performance a little bit, and whether the medical records based on blockchain might slow down, for example. One of the projects that I've worked with, I'm writing a business school case on this project called MedRec, which is out of MIT and now is being developed at Beth Israel Hospital. They're trying to put medical records on the blockchain. And they've run into a number of these different performance problems. Their initial conception of MedRec was based on a private Ethereum blockchain using proof of work, and they ran into a whole number of performance issues and scaling issues. If you can imagine kind of all the different transactions that would need to be put on a blockchain in the health record, even within one hospital, based, not including all the hospitals in the country, it would never work. So they've now switched to a different, they're still using a private Ethereum blockchain for MedRec 2.0, but they're now using proof of authority, which is more kind of like a decentralized database almost, more than kind of like a blockchain like Bitcoin or Ethereum, but it still is Ethereum based and still has this consensus mechanism that can afford a lot of the benefits of blockchain. So suffice it to say that this is the one way that I want to capture it, basically, is that physicians, especially physicians who maybe didn't grow up with the internet, or physicians who have never heard of Bitcoin before, the goal isn't to teach them how to use blockchain in healthcare. That shouldn't be the goal. When they start using their medical record, they shouldn't notice that blockchain is underlying it. It should just work, basically. And blockchain won't be accepted and it won't take off really until we can reach that level of user experience. In the same way that physicians now, when they use Epic or Cerner, they don't realize that, oh, this must have been coded on C++ or Python or something. It just works, and that's what we need with blockchain as well.
So I think Professor asked two questions. One is why healthcare healthcare data on blockchain is slow. To answer that question, actually, so usually there are two parts. First, healthcare data is usually too big, just too large for a blockchain. Like usually you don't put data on the chain. You put data off the chain, but you build an integration layer between, like on top of the blockchain. You either put a hash or whatever, like something onto the distributed ledger. And the second solution could be, as mentioned, either it could be private chain or the permissioned chain. Like even like say, so in our Google's use case, it might, if you are interested, you can search Trillion on Google. Like you will find this open source project working on healthcare data. Open source by Google. So what it does is the permission chain. So the validator is actually the UK government. The government agencies, the medical agencies will be the validator. So the node will be super nodes. So actually the transaction is pretty fast. So you need to worry about that one. For the second part of the question, it's actually about how we might improve the data overload. Data overload problem. For that part, I think that's actually a better problem to solve because previously we still have paper version of data. Like you don't even have the capability to just search the entire database. But now we have much better data. Much better problem to solve. And at that point, Google is really good at AI, deep learning. Right, then you can just run deep learning, run machine learning on it, do the AI suggestions. It's it's a much better problem to solve.
So I also don't think I would want to look at how many steps my patient took over a certain course of time. I'd like to see their weight go down and their lipids go down and things like that. But I do think that this data has the potential to be harvested and captured and analyzed to kind of come up with new policies and procedures to optimize health for everybody. But there's a lot of talk about self-sovereign medical records. And I think that's something that's really new and it's hard for a lot of people to wrap their head around. But the idea of owning your data, right now, Manny had alluded to the fact that we're spending a lot of time looking at Facebook and clicking, and every time we do that, they're capturing data about what we want to see. Google does the same thing. I'm sure you guys see ads pop up for something you wanted, and you wonder if they were listening to you. A lot of this has to do with data analytics, and we as a people are not really used to the idea of our time being valuable and our attention being valuable, but it is very valuable. People pay a lot of money for this data, and a lot of money for the marketing techniques that they implement based on this. And so similar in the digital health space, the data of patients is very valuable. And, we as physicians, as you said, are capturing data with these electronic health records, and, our time is being misappropriated to these non-care tasks. The impression from the general public is that we don't care about them anymore, and it's just not true. We're kind of being forced to do this because we're also, just like your data is trapped in these siloed healthcare systems, we as physicians are also trapped in those siloed healthcare systems. We have no other option. That's the only job we can find. A lot of us are strapped down to student loan debt, so we have to kind of just do as we're told. So I think that if blockchain is implemented properly, where the individual person, the self-sovereign person, whether they be a physician, a provider, or a patient, has the ability to move freely, interact with an excellent user experience where it's worked seamlessly, and then when people are putting work and energy and time and attention to things, those individuals are rewarded for that time and that attention and that energy. Patients are rewarded for their data, physicians are rewarded for the work, there's no more uncompensated administrative burdens. I think that that's what it comes on this side.
So that's a very wise comment. I'd like to sort of follow up on that. And it was mentioned this morning, one of the advantages of blockchain is that the data record is permanent. But when you look at patient data, there's a lot of junk data in there. And I've seen this with the family members who, like, I've sat with interviews with data intake people at hospitals, and then you look at the record and it's got no resemblance whatsoever to what they said. They've got conditions that they don't have, and medications are all wrong. So if the patient becomes sovereign with his or her data, on the one hand, you want the capability of correcting errors. On the other hand, insurance companies want to look at that data, don't want patients willy-nilly changing what's in there. So how do you balance getting accurate data records with not letting those people manipulate their data records and turn it over to insurance companies under false pretenses?
I can answer that. So I think that there's a little bit of a misconception, because I think right now where we're at from a technology standpoint is we're not going to have all medical records on blockchain. We're not going to have all the data on blockchain. We're going to have, as you said, and I'm not a technical person, so correct me if I'm wrong, but, we're going to have hashes that then connect to an off-chain, data. Right. And so, your CT scan can't go on blockchain. That's way too much information. So it's not that we're going to have all of your CBCs and all of your vitals there on blockchain, and patients are going to be like, I don't want him to know that, I have HIV, or that my glucose was 280 because I ate a cupcake that day. Those types of things, they're going to be subject to potential data decay because they're going to be off-chain. But what we will be able to do is find out and timestamp when things were happening and be able to correlate them to the off-chain data. So,
Sure, just to illustrate another way that could work is, so I mentioned MedRec at MIT. The way that their medical record works is, just like everyone has said, you can't put MRIs in the blockchain, you can't put even, x-rays or kind of smaller things in the blockchain. The way that MedRec works is all that is put on the blockchain are physician relationships with patients. So it will say this patient is assigned these physicians and they're allowed to add, medical files. And all it contains is pointers that point then to the actual medical record or the actual image, like an MRI, that is still stored on a central server at Brigham or at MGH or something. So what the patient can manage, the patient can't go and change the records. What they can manage is which of their physicians they confirm having a relationship with, meaning that the patient-physician relationship exists and that physician can then append blocks or not append blocks, but write records basically, add results, etc. The way that any physician does today.
Right, I think Leah and Ben is mostly covered my point, but I think the other reason we kind of need this more modifiability feature for the blockchain system is the GDPR, because it grants the user the right to forget. You want that functionality in place. That's why we also implemented Trillium for the UK government. And yeah, that's mostly it.
Yeah. So I think it's an issue. It may be an issue with local databases are stored, but as patients can get more access to the data, they're going to discover more things that are wrong, and then mechanisms have to be set up to correct errors, but not allow complete manipulation of the data. So let me just ask. I want to get one other brief question, and then I'll sort of an open-ended question. So one of the things that's been discussed is patients can sell their data and make it available. As people can do this more widely, which I think is a good thing, the privacy issues come up, because I remember I was talking to someone who was running a database and said, it was very minimal information that was sort of shared, which is the gender, age, patient had, and was in the ICU because of an automobile accident in Boston, such a date. Well, that information, you can find out exactly who that person is in a few seconds. So how does sharing the data, and is it just an unsolvable problem that if you start sharing medical data, you're going to be able to figure out who people are?
Yeah, I think that's a great question. It's very important, but I think that oftentimes the reverse is true. And an example is, if you compare two companies, compare 23andMe, which we're all familiar with, who owns this genetic data, and they're kind of the central point of failure that we have to trust these most intimate things about ourselves, our genetics and our ancestry and what conditions we might be predisposed to. So compare 23andMe to, there's a startup out of Harvard that Professor George Church is involved with called Nebula Genomics, which is a blockchain-based kind of version of 23andMe, which instead of trusting a company, a for-profit company like 23andMe with your genetic data, it instead gives that data back to the patient, and it's kind of secure via, I don't know the exact details, but using the blockchain, it allows the patient rather than a company to own that data. And so then the patient can create, if they want, relationships with pharmaceutical companies, and they can opt into having their data be analyzed by AI, et cetera, or pharmaceutical companies for, maybe they're thinking about, they're trying to recruit patients for the clinical trial. And then the point is that's a decision that the patient can make and that the patient can monetize rather than having a company like 23andMe make those decisions.
That's a very good point. Yeah. So I think the privacy is really, really an important issue, and it should be considered from the day one when you design the entire system. So in blockchain, there's a very promising technology called zero knowledge proof, as I mentioned before. So how it works is basically saying, when you say, give you an example, like if you go to a bar and the bartender will ask you, okay, can you show me ID? The reason he asks you for ID is because he wants to verify if you are older than 21 years old. But zero knowledge proof, what allows you to do is, instead of showing the entire ID, it only shows the data. It only shows him saying, okay, you are older than 21 years old, and it also shows cryptography proof, like saying, okay, this is the truth, like the verification you provide is true. So such kind of technology is very promising. So in theory, in the future, like all your personal data will be encrypted. So when you need to actually review data, you use a zero knowledge proof, only review the aggregation or summary of the data you need to show to the counterparty.
Yeah, it's interesting because, I was practicing medicine, and that's all I was doing up until I started learning about this stuff, and, learning about zero knowledge proof, and, those questions that they ask us, which of the four is true? You had a car in 1998, you own a house in this city, That's kind of the type of technology that it is when they build in cryptography that way, because you have to answer the questions just to show that you are who you are. And once you answer enough of those questions, they're like, okay, we trust that this person is who they are. So those types of algorithms, federated data masking, you can bundle your data, attach it to your identity, and mask it. So you can only share parts of your data and be rewarded with tokenized incentives. And pseudo-anonymization, where you can mask that who you are, but you can share certain data points that are valuable to systems that want it, and they can incentivize you that way as well. And what's really interesting about this is that, somebody took a survey to see who would want to own the record, and they said in this room about 20% of us. But we're also a crew of people that's, we're educated, we're interested in technology, we're interested in healthcare. And, the real number is, 1 or 2% of the population really want to own their data and control their data. And those are also the 1% that take really good care of themselves. And they already have all their records and know who their doctors are and have enough money to pay for healthcare. When I think about solutions in healthcare, I think about why I went into medicine to become a doctor. And it's to help people, especially people who oftentimes don't get help. And I think about patients in the emergency department. I look at the tracker and I see toe pain in a 32-year-old, and I'm wondering, okay, there are some life-threatening causes of toe pain. I'm thinking about them as I walk into the room, and there's a patient there who's disheveled, confused, schizophrenic, and I look at their foot to see why they're having pain, and it's black, necrotic. There's maggots eating their foot. that person's not going to own their data. But we need to understand that person's data in order to do the right thing for them, in order to be able to implement new technologies, in order to be able to understand how they got there so that we can prevent that from happening. And so this type of technology can make sure that that record is shareable while also protecting the patient's privacy. And so I think that that's some of the utility of some of this tech.
Okay, so I'd like to sort of ask an open-ended question. So this panel is about challenges to adoption of healthcare technology. So actually our panel here represents a good spectrum. We have one individual who's starting a new blockchain company. We have someone who's been involved in a number of healthcare blockchain startups, and we have one person who's working in a large company in this area. So I'd like to ask you, what are the challenges on an individual basis to starting these efforts? Is it getting funding? Is it finding clinical partners? Is it finding clients? What are the challenges that you're individually are finding in these various efforts?
So I think that the challenge that isn't really there is funding. I feel like blockchain is such a hot topic right now, especially in Silicon Valley. Everyone loves blockchain projects. They can raise a lot of money, especially if you look at ICOs. They can raise like way too much money sometimes. And so I think that instead, where the challenge is and where we need to work on is infrastructure. This is just so early still. And I feel like we're trying to plan out, it's like the 1990s and we're trying to make Facebook, or it's the 1990s and we're trying to make Uber or something. Like the ideas are good, they're good ideas, but do we have the infrastructure yet? Oftentimes in a lot of blockchain projects that I come across, the answer is no, and that's why a lot of my investments are still kind of these infrastructure projects, whether it's layered solutions like Lightning or kind of other really, they're not as exciting, they're not as sexy as maybe Uber on the blockchain, et cetera, but they're also more practical, and I think that's something that's necessary before we can run for the end zone.
Yeah. So from my perspective, because I'm technically working on those projects, so actually those blockchain projects is much harder than it seems, when you're saying it. So I think the first obstacle is definitely try to find a right angle to get into. For example, for the Google's DeepMind healthcare pilot project, the only angle we enter is auditability. So making sure the data, the entire data trail is auditable. That's the only angle. Like you don't tackle anything else. Because, once you find the right angle, right use case, then you find the right technology. And it's also not easy to find the correct combination, because there are so many things to consider. Like Dennis mentioned, if the technology is ready. So right now, a lot of there are so many different blockchain combinations, and a lot of them are either not scalable, or either the privacy is not considered at all. Then I think the last part is actually finding the right partnership and actually building the company.
So I think that there's, we're talking about, I briefly spoke about the history of technology and the World Wide Web and where we're at now with blockchain, just to kind of put this into context, because we're in the America Online dial-up phase still when it comes to blockchain. So there's a lot of solutions that are too slow, too clunky to actually do what they say they're going to do. There's currently, a lot of solutions looking for a problem where there isn't one. There's some solutions that are for a problem that are within the problem still. So they haven't really thought outside the box enough to really make a true solution. So those are some of the barriers, of course. But it goes back to the people. Are the people going to adopt it? Is there going to be, interoperability? Is the user experience going to be good? And as far as funding, so I'll just briefly tell everybody what I'm working on. I'm giving physicians a digital identity and attaching it to their credentials so that they can move freely in the open healthcare marketplace. Because as I said, physicians are currently trapped in these siloed systems. It takes 6 months to get a license in California. I'm licensed in California, Florida, and New York, and I spend 20 hours a year just updating my credentials, CMEs, thousands of dollars. All of this is validation and authentication that doesn't need to be done repetitively. I got my medical degree once. I only need to verify it once. Why do I have to keep verifying them? So there's a lot of that, and I'm crowdfunding from physicians only, so we're not doing an ICO or anything like that. So it's going to be a little bit harder for me because physicians are extremely skeptical. We are scientists, we are logical, we want to really understand it, we want to make sure that we're doing the right thing for ourselves, for our patients. But unfortunately, these other outside systems and these third parties and these special interests are in the background doing a bunch of stuff that they're going to impose upon us if we don't step it up and start acknowledging that we need to have a seat at this table. Because we haven't had a seat at the table, and that's part of why we have clunky EHRs and policies that are implemented that aren't really helping us. So those are some barriers that I'm facing.
So,
Can I add one more point?
yeah, sure.
Yeah, sorry, forget me. I mention one more point. So actually, when you are building a system, there's another thing you need to consider, like why you need blockchain. There are actually, say, digitalize your healthcare data. You don't really necessarily need a blockchain to build up data. Like the log trail auditability. You don't really need a blockchain. You can even do it with a database. Like what Google do, like we use a local tree, but we don't use blockchain.
Okay, so what I hear is that money's not a problem, technology is still a challenge, and the one issue which is true for any medical innovation is you need to find compelling clinical need, and you need to really target your innovation for something that's compelling. And once again, I've seen a lot of companies that have built very elegant solutions for problems, but they weren't really problems. There was no clinical need, and when they went to the marketplace, there was no demand for it. So you really need to make sure you've identified a compelling clinical need, which means you need to have observation back to people in the field and so forth. So we have a few minutes left. Are there any questions from the audience? Okay, first Mike.
Question to Google gentlemen. So I remember a while back, a long time ago, Google had a Google Health. It was a bottom-up approach that giving you the empowerment of people to enter their data on their phone or app on the web. But at one point, I remember it was killed. And now going back into the bit of the healthcare world. So, give us some context about what has happened, what you guys learned, and what you are trying to do something different.
Sorry, that information might be a little bit confidential, and even meanwhile, because I don't really work on Google Health, it's on people my side, like it's a separate division. Sorry.
The people I've talked to who were familiar with it or worked at the people at the Beth Digital Health work on that said it was a great system. So there's a lot of angst when I go. Another question in the back?
So I think for currently, like healthcare, every hospital, they have their own system because it's easier for them to communicate between different development. So I think blockchain can help to have a unified platform to communicate between a different hospital or different country. But it's kind of revolutionary that you have to turn the whole system into a different one for every single hospital. So that's kind of hard to do it. I was wondering whether you can start from basic research. For example, now we have human protein atlas database, where we have next generation sequencing. We can use those as a platform to show blockchain can actually be used for these data sets. And after we prove that it's actually doable, and also some kind of other AI learning technique is already being developed to specific finding those data that we need, then we move into the next step to really bring this system to healthcare. I think that might be a little easier.
Would you like to comment?
I missed what the question was, sorry.
I was thinking like whether we should actually promote the blockchain in basic research, like using basic research data set first, and then move into healthcare.
Yeah, I mean, I think the enterprise is definitely going to implement blockchain. I think they already have. You know, the American Medical Association has started ACARI, which is some form of blockchain data gathering, you know, infrastructure from what I can tell from the website. So, you know, I know that there's pharmaceutical industries opening up closed permission blockchains to put their data up. So I think that industry and enterprise is definitely going to adopt this before government systems and things like that.
Yeah. So I think if you look back to the history of internet, so internet is a very simple protocol, but it's very flexible. It has multiple layers of protocol. You have a physical layer handling all kinds of different physical machines, gateways, systems. You have network layer handling all kinds of different networks, even protocols. So I think for the blockchain system, you also need to find a very simple protocol, but it should be very adaptable to all kinds of different, very inclusive to all kinds of heterogeneous data or systems.
Okay, one last question.
Just one question, and I think maybe to Dennis. So, public health. So, I'm in Atlanta where the CDC is, and I've talked to them over their blockchain projects. They have 16 that they're working on now. They're blockchain upon. Oh, I'm sorry. Hi. Okay. So, I'm in Atlanta now where the CDC is, and I was asking Dennis this in particular. I'm talking to the MD there who is in charge of 16 projects over there. Blockchain department with regard to public health, yeah. And they've been involved for over a year, maybe 2 years working on them. So I'm curious if you happen to know, how they're going to use it. I mean, I've been hearing bits and pieces, of how they're going to utilize in the public health realm the blockchain, to be able to track, again, identities and who's really, who's got the TV in that plane that made it go to everybody, or who's, how is that going to be handled? Do we know, or maybe we know from Google how they're going to be doing that? Oh, they're pointing it.
Sure. So I can comment a little bit. Wow, that's incredible for Atlanta. They have that's a lot of blockchain projects. Yeah. So I think, so I don't know if it's the specific projects in Atlanta, of course, but the projects that I know about that are some of the ones that I mentioned kind of in my early introduction. Supply chain tracking, which can be very beneficial, in addition to medical records. Some of the ones I didn't mention also are in like provider credentialing as well. So some of the other ones, especially that are more public health oriented, are global health, for example. So if you think back to, so an example that I often talk about is, if you think back to the fall of the Taliban in Afghanistan, several years ago, the United States donated, I think, something like $230 million to help set up clinics and hospitals, kind of recreate the healthcare system in Afghanistan after that. And it was to tremendous benefit to the average Afghani. And I think the average, the life expectancy in Afghanistan rose from like 40, it was really low, to 60. So 20 years of added life because of this investment from the United States. The problem was, of this $260 million that the United States, USAID, gave to the Ministry of Health in Afghanistan, something like 60 million of it was diverted and lost. And this is something that blockchain can solve.
Digitalize your healthcare data. You don't really necessarily need a blockchain to build up data. Like the log trail auditability. You don't really need a blockchain. You can even do it with a database. Like what Google do, like we use a local tree, but we don't use blockchain.
Okay, so what I hear is that money's not a problem, technology is still a challenge, and the one issue which is true for any medical innovation is you need to find compelling clinical need, and you need to really target your innovation for something that's compelling. And once again, I've seen a lot of companies that have built very elegant solutions for problems, but they weren't really problems. There was no clinical need, and when they went to the marketplace, there was no demand for it. So you really need to make sure you've identified a compelling clinical need, which means you need to have observation back to people in the field and so forth. So we have a few minutes left. Are there any questions from the audience? Okay, first the mic.
Question to Google gentlemen. So I remember a while back, a long time ago, Google had a Google Health. It was a bottom-up approach that giving you the empowerment of people to enter their data on their phone or app on the web. But at one point, I remember it was killed. We're now going back into a bit of the healthcare world. Like, give us some context about what has happened, what you guys learned, and what you are trying to do something different.
Sorry, that information might be a little bit confidential. And even meanwhile, because I don't really work on Google Health, it's on people my side. Like it's a separate division. Sorry.
The people I've talked to who were familiar with it or worked at the people at the Beth Digital Health work in the centers of great system, so there's a lot of angst when I go. Another question in the back?
So I think for currently, like healthcare, every hospital they have their own system because it's easier for them to communicate between different development. So I think blockchain can help to have a unified platform to communicate between a different hospital or different country. But it's kind of revolutionary that you have to turn the whole system like into a different one for every single hospital. So that's kind of hard to do it. I was wondering whether you can start from basic research. For example, now like we have human protein atlas database, or we have next generation sequencing. We can use those as a platform to show like blockchain can actually be used for these data sets. And after we prove that it's actually doable, and also like some kind of other AI learning technique is already being developed to specific finding those data that we need, then we move into the next step to really bring this system to healthcare. I think that might be a little easier.
Would you like to comment?
I missed what the question was. Sorry.
I was thinking like whether we should actually promote the blockchain in basic research, like using basic research data set first, and then move into healthcare.
Yeah, I mean, I think the enterprise is definitely going to implement blockchain. I think they already have. The American Medical Association has started Akari, which is some form of blockchain data gathering, infrastructure from what I can tell from the website. So, I know that there's pharmaceutical industries that are opening up closed permission blockchains to put their data up. So I think that industry and enterprise is definitely going to adopt this before government systems and things like that.
Yeah. So I think if you look back to the history of internet, so internet is a very simple protocol, but it's very flexible. It has multiple layers of protocol. You have physical layer handling all kinds of different physical machines, gateways, systems. You have network layer handling all kinds of different networks, even protocols. So I think for the blockchain system, you also need to find a very simple protocol, but should be very adaptable to all kinds of different, very inclusive to all kinds of heterogeneous data or systems.
Okay, one last question.
Just one question, and I think maybe to Dennis. So, public health. So, I'm in Atlanta where the CDC is, and I've talked to them over their blockchain projects. They have 16 that they're working on now. They're blockchain projects. Oh, I'm sorry. Hi. Okay. So, I'm in Atlanta now where the CDC is, and I was asking Dennis, this in particular. I'm talking to the MD there who is in charge of 16 projects over there. Blockchain department with regard to public health, yeah. And they've been involved for over a year, maybe 2 years working on it. So I'm curious if you happen to know, how they're going to use it. I mean, I've been hearing bits and pieces, of how they're going to utilize in the public health realm the blockchain, to be able to track again identities and who's really,
who's got the TV in that plane that made it known to everybody, or who's, how is that going to be handled? Do we know, or maybe you know from Google, how they're going to be doing that? Oh, they're pointing it.
Sure. So I can comment a little bit. Wow, that's incredible for Atlanta. They have that's a lot of blockchain clusters. Yeah. So I think. So I don't know if the specific projects in Atlanta, of course, but the projects that I know about that are some of the ones I mentioned kind of in my early introduction, supply chain tracking, which can be very beneficial, in addition to medical records. Some of the ones I didn't mention also are like provider credentialing as well. So some of the other ones, especially that are more public health oriented, are mobile health, for example. So if you think back to, so an example that I often talk about is, if you think back to the fall of the Taliban in Afghanistan, several years ago, the United States donated, I think, something like $230 million to help set up clinics and hospitals, kind of recreate the healthcare system in Afghanistan after that. And it was to tremendous benefit to the average Afghani. And I think the average, the life expectancy in Afghanistan rose from like 40, really low, to 60. So 20 years of added life because of this investment from the United States. The problem was, of this $260 million that the United States, USAID, gave to the Ministry of Health in Afghanistan, something like 60 million of it was diverted and lost. And this is something that blockchain can solve. I mean, if you use